Oh, sorry. Good morning, everyone. Welcome to the July meeting of the Universal Health Plan Governance Board. We'll get started with a roll call.
Yes. Helen Blanca,
Here.
Shanwei Chi. Here. Amy Fellows. Here. Michelle Glass. Bruce Goldberg.
Here.
Judy Richardson.
Here.
Cheryl Ramirez. Mary Lou. Hi.
Here.
Here we have a forum.
Okay, great. So quick agenda review. Today we're going to be spending a little bit more time in the strategic direction discussion that we started last time. There are just a number of sort of high level issues that we want to have some discussion at the board level about that will inform our committee work and our consultant work. Judy's going to be doing a presentation about risk. And then we're going to be talking about the regional entities and what those might look like. And then we have our typical committee updates, and that should round out the meeting. I want to thank all the members of the public who took the time to submit written public comment for this meeting. This month, we heard from Claire Schurmeister, Robert Price, Beverly Rugel, and Justin Wood, who all expressed general support for our work. Thompson Sick wrote to recommend that our mission statement not use terms like minimize financial burden, but instead use language from the statute like protecting individuals from financial consequences of ill health and or removing cost as a barrier to accessing healthcare. And he advised we not use the term sustainable as it is undefined. He also had feedback about the eligibility proposal and how we define resident to remind the board that issue is currently with our agency partners to be in compliance with other state level programs and agencies. And then finally, Tom recommended that providers not be allowed to bear risk in the plan. Bruce Thompson sent a YouTube link of a video of a commentator that was discussing Oregon's new corporate practice of medicine law. Cassandra Cassidy wrote to express hope that the Universal Health Plan would cover some brand name prescriptions in certain cases and not just generics. Tricia Hayden, apologies for my pronunciation, wrote to express hope that the Universal Health Plan would cover incarcerated persons and to remind the board that is included in our eligibility proposal currently. Drew Essig wrote to express hope that the Universal Health Plan would cover gender affirming care, and of course that's also in our benefit package. Rick Handgardner asked how the money we use for consultants will be spent and included links to multiple media stories about the new federal legislation regarding healthcare funding and the fund that has been set up for rural hospitals. Tricia Kendall expressed hope that mental health services would be prioritized in the plan. Carrie O'Connell wrote with concerns that a universal health plan might inadvertently interfere with reproductive rights because of the restrictions of the Hyde Amendment. And as a reminder to the board, the Oregon State has now a constitutional amendment that provides a workaround to that. Okay, great. Next agenda item is to approve the meeting minutes for June. Do I have a motion to approve the June minutes?
So moved.
Seconded by Amy. We'll do a roll call vote, please.
Helen Blanca,
Yes.
Shanwei Chi. Amy Fellows. Yes. Michelle Glass.
Yes.
Bruce Goldberg.
Yes.
Judy Richardson.
Yes.
Cheryl Ramirez. Absent. Mary Lou Heinrich.
I abstained because I was in and out of that meeting.
Okay, great. And just double checking, I don't believe we have any public comment.
We do.
Oh, we do for voting issues?
First for the central vote, yeah.
Okay, great. Who do we have?
Tom. So I will pull up the timer.
Is for Tom?
Yeah.
Okay, great. Okay, great. So,
Can I just sit here?
yes, I think that's fine. Is it there? Yes.
Okay, great. Okay. Hello, my name is Tom Sinsick, a retired family nurse practitioner. As for those that don't know, I was intimately involved in writing of all legislation regarding the Universal Health Plan Board and the previous Joint Task Force on Universal Health Care. I'm here to comment on kind of the combination of regional entities and risk-bearing entities. Kind of works together. Basically, there is no specific reference to regional entities in the statute of ORS 751, but there is that mention, as you'll see in the slide, of about the reference to the Joint Task Force recommendations of regional entities. So that's great. There is mention of regional planning, regional organizations, and mention of coordinated care organizations. But regarding risk-bearing entities, as used in this section, this is from the statute, single-payer healthcare financing system means a universal system used by the state to pay the cost of healthcare services and goods in which institutional providers are paid directly for healthcare services or goods by the state, or paid an administrator that does not bear risk in contracting with the state. Funding for the Universal Health Plan is a public trust, and any savings or excess revenue shall be returned to the public trust. So that means not to the entity providing services. The plan shall cover all services from birth to death. The language related to regional entities in the Joint Task Force was never written to be interpreted as risk-bearing, and must now not be done so now. The upside of risk or shared savings, there is no upside at all, and completely out of line with all legislative intent, and is degrading to care providers. Personally, I never provided best care possible with great quality outcomes so I could get some extra money in my pocket. It is time for transformation. Thank you very much.
Thank you, Tom. Is there anyone else for public comment? No? Okay. Great. Okay, so I will pass it now to Mimi McDonald for the Executive Director report. Mimi, I'll pass it to you now for the Executive Director report.
She's moving her eyes.
Can you hear us, Mimi?
Pardon me.
Mimi, can
Yes,
you-
this is Mimi. Are you guys able to hear me? Oh, yeah, I can. You guys able to hear me? Okay, I apologize. I'm joining you from beautiful coming here from Breckenridge, Colorado, which is beautiful, but my Wi-Fi is not, so my apologies. You guys can just let me know. So I'm here to give some administrative updates. One of my first, and what I'm so delighted to do, is to introduce Lee Hastings, who is our new Senior Policy Advisor. So Lee, if you wouldn't mind doing a bit of an introduction for yourself, that would be fantastic.
Absolutely. Hi, everyone. I'm Lee Hastings. I'm the new Senior Policy Advisor. I've been doing healthcare policy for the last 15 years with a strong focus on value-based payment arrangements. So very, very excited.
Welcome.
Yeah, Lee just brings a wealth of knowledge to this position. Of course, we miss our former Kim Yee, but so excited to have Lee on board with incredible energy and background knowledge. So I am delighted. Also delighted to say the board position candidates, 3 were submitted to the governor's office. So that decision will be made later in the autumn, and then we will have a new person to be on our board. Other exciting news that the contract with Patty Wentz is signed, and Patty has begun work, which is delightful. And also the contract with our other major consultant group, Milliman, has been signed, and we're working with them to get a kickoff meeting time. And then just one other update, just to ensure that people have the understanding. I know from the separate committees, we always go over their work plan and timelines, but just to let the entire board know that at this point, all of the committee work and the work plan that you all developed so well in 2024, things are on track to have everything completed in a timely fashion by September, September 2026, in time to submit this report to the legislature. Next, if you go ahead, I'll do a brief budget update. All right, so this is our the Universal Health Plan Governance Board budget as of May 2025. So this is the money from the prior biennium. And again, as you can see, On the far right-hand column is actually the amount that is currently projected that the budget will go under the estimates, with a total currently looking at 676,000 roughly. As we mentioned in our last meeting, a lot of this had to do with delays in getting our major consultant groups on board. And then if we go, I thought it would be very valuable for the board to have a sense of where we are going to be in the next biennium in terms of funding for our consultant groups. So if you wouldn't mind going to the next slide. Thank you. So what we have now, this is not exhaustive. There are a few of our consultant groups that we use mostly for interpreter and translation services that are not listed here. These are the major contracts that we have. So we have the names of the consultant group. Total NTE stands for not to exceed, which is how these contracts are written. Next column, overpaid to date, is just what it seems, and monies that have already been spent. We have what is the balance. And then in the upper right-hand corner, and again, this is very preliminary, but based on our current budget estimates, which the official legislatively approved budget has not been released, but in terms of the voting, it went along with the governor's budget. So we feel confident that we will have all the funds that were requested. But you can see that our professional services, again, will take the vast majority at approximately 1.1 million. And then if you look going down the list, if every single consultant group went completely to their maximum, that would end the board up at 947,000 and somewhat, with only 173,000 remaining for other consultant groups. Now, what I would like to say, it is highly unlikely that those big consultant groups are going to meet that not to exceed. And so I just wanted to give everyone sort of a ballpark sense of where the board is at, and that as we move through, especially I would say the next 3 months, we'll have a much better sense of what our major contractors will be charging monthly, and get a much better sense of what the ultimate payout is more likely to be, and we can make budget adjustments as needed. So I'll stop there. And again, apologies, I'm not sure how bad my audio is. Any questions?
I have a question, Mimi. Thanks. Yeah, your audio is just great on that. So even though we had a pretty big delay in signing the contract for Milliman, and that we cannot carry money over from one biennium to the next, even with those conditions, we still can fund that Milliman contract completely in the next
Yes.
biennium. Yeah,
That is
Okay.
correct.
That's great. Any other questions for Mimi?
No, Mary Lou, I just want to say thank you that this is helpful. I had called Mimi and just kind of wanted to feel for where we were at going forward, what we committed to, what we had left. And I just guess I need to say for the record, I think it's sad that we ended up handing back $676,000 to the general fund, but I can understand all the reasons why that happened. But I think for this board to kind of have a sense of each kind of month going forward, where we're at, and what other contracting things or other stuff that we will potentially need, are we going to have enough to get through and do what we need? And if not, how will we proceed with that? So anyway, I'm thankful to see this, because I was feeling like a bit, and I'm new in the game a bit, but I was just feeling in the dark. So thank you.
And just a reminder that Patty's amount is very small, but part of her contract is to help give input for a RFP for longer term strategic communication that we will definitely need. So part
So
of
yeah.
to go towards that. So
Yeah, I think Mimi would agree with me that one thing we've learned is it's incredibly hard to spend money through a state agency. Like the process of contracting with consultants is very long, very difficult, and there are many sort of obstacles to getting contracts signed, especially for bigger dollar amounts. We knew that with Morgan, we went through that, and now with Mimi, we're learning that it's actually pretty hard. So we've done our best, I think. And as Mimi said, we are on track for our deliverable, which is the key. I think we've got excellent contractors who are doing outstanding work right now. And as Mimi said, even if all of our contractors reach their not to exceed amount, which they're unlikely to do, we're still pretty good under budget. So I think we'll be fine in terms of getting the work done that we need to get done. And I'm so grateful to Mimi for both giving us a budget update and a timeline update at every board meeting. I think that really helps to know that we're on track. So yeah, thank you for that. Any other questions for Mimi? Okay, great. Thank you so much. I'm going to pass it now to Judy. She's going to do some follow-up of our discussion from last month about the mission statement.
Good morning, everyone. Hopefully you can hear me okay. Thank you for all of your work during our strategic planning session day, wordsmithing and thinking about all of those really important elements in our mission, which describes essentially our why, our reason for being, the reason we're here and labor voluntarily on this board. So go ahead and next slide. What I did was took your comments and I shaped them into 5 different options that I believe have the intention of the members in each of these. And then our goal was to take them and hand them off to Community Engagement and Communications Committee to look at translating into plain language, have those come back to the board, make sure that the intention, which I'm sure it will be, but that everyone feels that the intention reflects with fidelity the aims, the principles, and your wishes in the mission statement. So what I would like to do is read those 5 and take a census, a general gestalt, if there's one that we can cross out so that we can at least make this work a little bit more manageable for Community Engagement and Communications Committee, although I'm sure they are up to the task. How does that sound?
That sounds good. Patty did take the staff also, and we just saw it, and Michelle and I are meeting with her this afternoon, so maybe we can figure out how to merge and make sure we get Patty's input on whatever comes out.
Right, so our role as the board is to make sure that the key elements are there. Are the key elements of what we want to say there, and then in terms of the wordsmithing or the plain language, turning that over. So yeah, as Judy said, if there's something in here that we can remove, just to give less.
And I think it's like less wordsmithing and more strategic communication and kind of understanding, you know.
Right.
That part, yeah.
Right. Yeah, so these are the 2 that we looked at last month, right, Judy?
Mm-hmm.
And then there are 3 others.
Was that in our, on the website?
Just a general comment, not so much about this thing, but I personally don't work well at a meeting like this with slides. I would like to have a printed copy of something that had the 5 things that I can look at and I can mess around with, because it's hard. I don't know, it's just my brain, but I don't do well.
So we
without
post
something
our
printed. It's
presentation.
not posted.
These
Oh,
are
oh,
not
oh, oh.
posted.
Yeah, so we make every effort to get an updated presentation.
Yes,
in
and I
advance.
looked at that, but I'm just saying
Yeah.
that while we're sitting here considering it today,
Yeah.
that is, I'm trying to remember what the first 2 say, and then I've got another slide with 3, and I'm just having difficulty.
Okay.
Thank you for that comment, Mary Lou, because I also am a visual person and I like to noodle on things in the quiet of my office as well. My inclination, and I would defer to the chair, but my inclination is we're not under a time pressure. We don't have to have the final mission statement today or even next month or the month after. It's nice to have it codified so that as we're speaking about our work, people are asked, well, what do you even do? And we can say what we do. It helps to bring us together cohesively. But we're already showing up and doing the work regardless. And so I would be inclined to letting the members noodle on this. We can see what Community Engagement and Communications Committee has for us to review. I don't think there is a time pressure. Helen?
Yeah, I agree. I agree.
That's good.
Yeah.
Okay, great.
So Chair, I would respectfully move to just to table this conversation. We can bring it back at another board meeting. Oh, Michelle, sorry.
Thank you, Judy. So can I ask a process question then, just so we have clarity for our committee and our consultants? If we're tabling this, what does that mean? Does that mean we should pause taking it to Patty and the CECC? Should we proceed? And then if board members have thoughts within a period of time, do they send those to us to incorporate in that process and we bring back a status up? Like, where are we in terms of process?
I think, Michelle, thank you for the question. And I'll send it over to Cheryl in a minute. I think at this point, we would pause, let the board members look at these 5 statements, think if one really doesn't fit, or we really just do not think one or even 2 of them are off the table, and then consolidate around those remaining ones, have consensus, and then send that over to communications, to wordsmith and to put into plain language and then bring back to us. It would
And,
be the way. Yeah.
and I'm just wondering, would the board want to see the couple that Patty drafted, if they're taking time and looking at these?
Yes.
Sure.
Yes. Look at all of them. Give us a little time.
Great. Yeah. So
Cheryl.
go ahead, Cheryl.
I was just going to make a suggestion that you give us just a certain, like a time limitation to provide feedback, like a week or something like that. I can live with that kind of a deadline instead of just waiting till the next board meeting and hold the communications committee up. That just give us a little time. I'm also like everybody else, I think, in that I like to look at things like this by myself and have a chance to think about it.
So let's take these. Judy, you want to? Okay.
Go ahead.
These 5 that Judy has on the slides, plus the 2 that Patty Wentz has already come up with. We'll email them to all the board members, and let's take 2 weeks. 2 weeks. Please consider that your homework to kind of look through these. You can rank them in terms of what order you like them. You can cross out things that you don't think are applicable. Any feedback that you have on them would be appreciated. And then please get them back to Isabel in 2 weeks, which is which day, the 31st? Yeah, July 31st, by the end of July. Thanks.
And also by the end of day to Isabel, Patty's.
Excellent. Great, thank you. Okay, great. Thanks, Judy.
Appreciate that kind of work. It's not easy. Yeah. Mission statements or vision and mission and all these very difficult.
Okay, so we have time now for a little bit of discussion regarding strategic direction. Next slide, please. This is a slide that I showed last time, which is just kind of a sketch of how this universal health plan would work. The blue boxes are sort of the big pieces of the puzzle. The green boxes represent some questions or some unclear aspects of the plan. Today we're going to talk a little bit about risk and about the regional entities and what those might look like, and kind of consider various aspects of that. So the legislation that created this board asked us to build a plan where the state is the only risk-bearing entity. And there are pros and cons to that idea. We certainly will do that. And I think the question we should consider is whether or not we want to explore other models in addition to that. We don't have to, it's just that's something for the board to consider if that would be of use to us to consider other models. So to get us started, I'm going to turn it over to Judy to give us an overview of risk, and then we'll go to regional entities.
Thanks, Helen. So, like much of our work, I'm reminded by communications and community engagement that we are public facing and we should speak plainly and specifically about the words that we choose. And when we're talking about risk, I don't want to assume that everyone is interpreting that the same way. So I thought it would be a nice moment to pause and have this conversation. So financial risk isn't just about insurance, it's about who's responsible and bears the cost when healthcare expenses don't go as planned. Next slide. There we go. So financial risk is the responsibility for paying when the actual costs they differ from what is expected. And the more risk an organization bears, the more incentive and pressure to control the costs and improve the outcomes. The implications for capitation, that's where you have to perform under a budget without quality expectations, include under provision of services and shifting costs to other entities, including beneficiaries, which can be often subtle or covert ways that most beneficiaries may not be able to discern the cost shifting. We'll talk at the end more about the pros and cons of assuming risk. So go ahead to the next slide. I just stuck this one in there as a glossary of terms for your reference. I would recommend, if you're unfamiliar with these terms, to print them out and put them in your notebook, because sometimes they get thrown around without definition. But I would say for public risk-bearing entity, or PRBE, that's a functional term used to describe a government organization or quasi-government that accepts the financial responsibility for a group. Single payer, most of us know what this is, when one public entity, could be a state, single payer, is responsible for funding and managing the health coverage system. And in that case, the state's the risk-bearing entity. A state-sponsored plan administrator is when the state contracts or can delegate with for the management of that to another body, so the administrative services. Global budget holders sometimes use, and that's where the state or a regional entity is responsible for managing a fixed budget. This is like the CCOs. And then sometimes you hear a purchaser or funder of care, and that's sometimes comes up in policy documents, and it reflects the financial accountability. Go ahead next. So here's an example. Let's think about a provider group that's given $10,000 to care for 100 patients. What happens if you don't spend the full $10,000 that you thought you needed for their care? There's money left over. So if you save money and if you meet certain quality targets, think about CCOs, then the entity sharing in upside risk can keep some of that savings. Mr. Sicknick talked about upside risk. This is part of the risk discussion. This may be why certain entities really do want to bear risk, because they see the opportunity to save money in caring for a group of patients. Theoretically, then can use those funds to reinvest in the care delivery model. Next slide. But what if the provider group ended up spending more than $10,000 taking care of that group of 100 people? That could be one person who is very unlucky and gets really sick, or a group of folks who just have higher needs. Say they spent $15,000, and who's going to be responsible to absorb that extra cost? So this is essentially a penalty. So if the costs are more than expected, someone's responsible to absorb that amount, and that's the downside risk. So both of these ideas often get lumped in when we talk about risk bearing. There's upside and downside risk. Generally speaking, we're really thinking about who's on the hook if you spend more money, if the population costs more than you anticipated. Okay, next. So if you're the group that's taking on risks, you need to have a process for attribution of patients. That is figuring out who you're taking care of, who belongs to you, who are the patients who belong to the group. You need to have a process for care coordination. So one of the markers of what we see in the broken healthcare system is fragmentation of care. To coordinate care, make sure that we reduce redundancy and folks get just the right amount of care at the right time. You need to have a process for data analytics, preventative care, and aligning the providers under that model so they understand what is within the boundaries and what their incentives are all about, how they're trying to show that their outcomes matter. Next slide. So here's the upshot. Risk bearing is about accountability for cost and quality. If you hear the term upside risk, that's about sharing the savings, if there's savings under a budget, taking care of a population. Downside means somebody has to pay if you go over budget. We can see that the Oregon CCOs, they're really a real world model of shifting risk to improve value. So value equals quality over cost. That's the value equation. Okay, and one more slide, I think. Yeah, sorry, the print is small. But if you are an entity that's taking risk, there are some pros to that, and there are some cons to that. The pros would be that there's a potential to align incentives and promote value over volume. We think this is really the key to reducing the escalating costs in a fee-for-service model. The risk-bearing entities are financially incentivized to improve outcomes and reduce unnecessary services. It encourages preventive care, chronic disease management, and care coordination. Another pro, especially if we're talking about regional entities, is that there's local accountability and flexibility. We know that if you even look at all of the CCO regions, populations differ. They differ in their needs, their demographics, their experience, and their access to healthcare. The third pro is that there's a potential for cost savings. We can reduce administrative redundancy through coordination and data sharing. The fourth pro is integrated care delivery. It can support team-based care and integrated delivery systems. And the fifth one is because we rely on the data, it can show data-driven improvement. So risk-based models encourage investment in analytics and population health tools because you're managing a whole population. It can promote learning systems and rapid cycle quality improvement, especially if there's shared savings, reinvestment, and improving the care model. There are some drawbacks. So entities taking on risk expose themselves to financial vulnerability. If the cost projections are off, the entity might face large losses. There are some ways to mitigate this, but really the first con is they're on the hook if they come over budget or they're unpredicted expenses. The second big one is an argument we've heard a long time about capitated care, and that's the potential for care rationing, or quotes, forgive the term, cherry picking, where you really want the healthy patients but exclude patients who potentially could cost more and denying services. So that's a big one. The CCOs try to mitigate this impact by requiring quality outcomes. It is sometimes hard to measure quality. The third con is there's a potential for market consolidation and power imbalances. We think that market consolidation reduces patient choice. The fourth is that there can be complexity in the implementation. It does require some sophisticated infrastructure for data sharing, making sure that the electronic health information is both secure but accessible to providers. And smaller or rural regions might lack capacity to effectively manage their risk. That one was just from Michelle, my fellow friend in rural Oregon. And then finally, there can be some equity concerns. Regional risk models might inadvertently perpetuate disparities if they're not designed with equity in mind. And some areas with higher social risk might face penalties unless the risk adjustment is done well. So the take home is that the more risk an organization bears, the more incentive and pressure to control costs and improve outcomes. Helen, what did I miss? I think there was something else we were going to add.
No, I think you covered it really well. No, I think you covered it. We were talking about, the advantages of just using data to, you have more control. So the smaller the risk-bearing entity is, you have more control over that population. And so you could potentially use data to make better improvements. But then the bigger the risk pool, you have less of that control, but also it's a lot easier to accommodate financial downturn. So the bigger the pool that is bearing risk, obviously that's a little bit easier to manage. If you get a very, very small pool of people and you're managing risk, the variability of your cost is going to be much greater. So it's a predictability versus, you know, control and the size of the pool that you're managing.
Other
Does it-
questions?
we've all dealt with other issues with risk. Does anyone else have comments about pros and cons of bearing risk and things to consider?
I'm not sure where this fits, but maybe the next part, the regional entities, but I'm just wondering. In our current system, there was allowance for CCOs to be owned by for-profit corporations. At least one of ours is that model. And I just
Several.
wanted several now, yeah.
Yes.
So I just wanted to put that out there and like, in whatever we're creating, make sure that we're considering not
Yeah.
doing that.
Yeah, I think that comes in our next
Okay.
conversation about regional entities.
All right.
Yeah, go ahead, Bruce.
Well, I'm just not sure what questions were answered.
Yeah.
I don't know that this is a dyad decision of regional versus not. I think the question for us should be who and where should risk be borne? I mean,
That is our question.
that's the question, but to think about, should it be a regional entity or not? I don't know. You can bear risk in a lot of different ways. You can
Right.
create a global budget for hospital care. That's not necessarily that, who manages that and how that gets managed isn't about a regional entity. And then what a regional entity is becomes really important, because I think as Amy pointed out, if a regional entity is an insurance company from Indiana,
Right.
that's really different from some new kind of organization. So I'm just a little confused as to, I think we need to clarify the questions we're
Right.
kind of thinking about.
So, right, so the legislation requires us to build a plan where the state is the only risk-bearing entity. And the question that we're posing is, should we consider other models? That's the question. We are giving right here just a background on risk and how risk works. And then we're going to move into a discussion about regional entities and what those could look like. And then ultimately, the last slide is a slide of questions to consider for the board to consider and discuss. So, but right now, this is just sort of background on what risk is and pros and cons of, and like things to consider. What are the benefits of a small organization bearing risk versus a large organization, and just as a background. And then as we move into the next discussion, I think the questions will be clearer. But the idea is, should we consider other risk models other than the state as the only risk-bearing entity, which we're certainly going to do that one.
I'm just questioning why we didn't do that one first, if that's what our kind of directional guidance is.
Why we didn't do one? Oh, of course, that's,
I guess like why didn't we dig into that first before having this conversation? I guess it kind of feels backwards to me. I don't know. Well, then,
My intention was just to set the table and make sure we were talking about the same thing when we say the word risk. And then I think Helen has, and Dr. Goldberg, you have primed the conversation moving forward. She was getting ready to launch into, well, who then? This is like the what bit, right?
yeah. Go ahead, Mary.
I guess my question is not who, it's why. You know, I really entered into this thing, having kind of looked at in my mind, kind of the mess that we have, where we've got all these different, quote, regional, but they aren't all regional, and they're nonprofit and profit, and they're all, and we designed that years ago and really had great hopes, and it's provided some, you know, payoff, but there have been some downsides. But to me, all of this has to do with the larger the group, and I think you said this on, that then you do have you get everybody under the same tent. That's kind of been my goal, is because things, you know, I come from public health originally, and really looking at prevention and how to really change the way that we do care for lots of people. And what I ran into when I was, for 10 years at Care Oregon, in those early days, if you divide it up, then, and you have other, especially in the metro region where we had, overlaps of us, et cetera, and we each had, something, you couldn't get everybody under the same tent in order to really do the prevention. So I guess I'm kind of going, I'm not sure why this question, but maybe it happened before I came on the board.
So that's exactly what we're talking pros and cons. When it's a smaller group, you have more control, you can make more changes, you focus on quality. When it's a bigger group, it's easier to bear the financial risk. There are pros and cons to both, right? And so let's move on. Let's go into the regional entity. I think that we're all starting to have the discussion that,
One comment
Yeah.
first, not about regional entities. I just think we need to figure out what problem we're trying to solve. I mean, that's the first, and I think we have to think about the difference between risk and management. And they're two different things
Yeah.
about who's gonna bear risk, but there's who and how are you gonna manage care.
exactly.
It's a different discussion. I just wanted to get those issues on the table, because I think it just seemed like we were creating a duality that maybe doesn't exist or shouldn't.
So we've been asked to consider the recommendation of the task force, who recommended that there be regional entities involved in this universal health plan. And the main problem that we're trying to solve is, what are those entities and what's their role?
Mhm.
What do they look like? Who runs them? Do they overlap? Are they for-profit, not-for-profit? Are they risk-bearing, not risk-bearing? Do they just do administrative services? Like, that's the problem that we're trying to solve. And so we're gonna go into the discussion about like what we know so far, what's been done so far about regional entities. And then we should come up with what we believe those groups should do, if they just have a management role or if they also have a risk-bearing role. Go ahead, Mimi, I'm gonna hand it over to you.
Okay, thank you, everyone, and apologies, I'm just going to stop my video so I have a little bit more bandwidth. And just briefly, this is a reference slide. So this information comes from the Joint Task Force report. Of course, when they are describing the role of regional entities, it's not exhaustive because it's not the entire report, but it really hits the highlights. And again, as Helen was speaking about, that there is a recommendation that there are regional entities and that the plan and the board will operate in partnership with them. And the description of the entities is that those entities will convene and collaborate with stakeholders in the region. They will advise with, and again, that's advise, that doesn't mean they're necessarily in charge of, but will advise with relation to coordination and delivery of care. They may advise, there's that word may, on budgets, reimbursement methods, and capital spending. I think this is an interesting part. The public entity that governs the plan will set global budgets for each region. Now, again, this is a recommendation of the Joint Task Force, and so I think, again, this is why Judy and Helen are bringing this up. This is the recommendation. What are the thoughts of the board at this time around these global budgets? So if we, again, this is still sort of as a reference from the Joint Task Force. And then if you go on to the next slide, please. And then just to cite the ORS chapter 751 that came from our House bill, that the ORS says to consider that recommendation of the Joint Task Force. So this is our Universal Health Fund Governance Board. We are supposed to consider this recommendation. So including their recommendations regarding the single payer healthcare. So again, just trying to make sure everyone's aware of all of the history and all of the work that went into where we are now. And so then going on to the next slide.
Mimi, can I interrupt you for 1 second?
Please do.
Judy, I wonder if you could clarify, when we say global budget for a region, how does that relate to risk and risk bearing? Like if each region had a global budget, is that the same thing as them bearing risk?
Well, it implies that you're taking downside risk. So you have only a certain amount of money to take care of a certain specific group of patients. And so the goal is to provide all the care that those patients need under that budget until it's renewed, usually annually. So yeah, it implies downside risk or upside as well, because you haven't really said what happens if the hospital or the entity taking on risk comes under budget. That can be specified. Like if it's a non-for-profit, you can say you have to use the rest of this money and reinvest in the delivery system, example.
Right. So the kind of the tension here is that the legislation that created this board asked us to build a plan where the state only bears risk. And then the task force recommendations recommended that we have these regional entities that function under a global budget. And so it's our job to just consider both of those things and decide if we want one model or the other, or if we want to look at both and compare and contrast in terms of costs and benefits and risks. So that's what we're doing.
Just a point of information. I'm not sure, well, I am sure that when the task force discussed this issue and used the word global budget, that they thought about that in terms of taking risk. I think they thought about it in terms of a budget. They didn't land on specifically that the regional entity. There was really no discussion about that. You could be given a budget, the risk is still borne in the state.
Can you explain a little more about how that would work?
That you would get a budget, if you go over, you ask the state for more money. I'm just saying, the task force didn't get into the issue of bearing risk. And we talked about a lot of different things, global budgets, global budgets for hospitals, I mean, a lot of different things. I just would point out, I don't think there was a really detailed discussion about how this would work or a clear recommendation that these regional entities would be this way.
Yeah, so it's a little hard to interpret that language. The advantage of doing it that way would be controlling costs.
Yeah.
Because we don't have unlimited funds, and certainly not in the current environment. There is a limited number of healthcare dollars. And if every region is going over budget every year and asking the state for more money, there's a breaking point there, right? And so one advantage of a global budget for a region that, and having that mean that they're risk bearing, is to control costs, right? To keep a cap on how much money we spend each year total on healthcare. Right?
Yeah, although again, how you control cost and where risk is born
Yeah,
can happen in a variety of ways.
yeah. Sure. Okay, go ahead, Cheryl.
I just wanted to echo Bruce's comment that I don't recall having a discussion about risk, whether upside or downside. And I know that would have perked my interest because just from my perspective, the behavioral health system is not ready for downside risk. You have to actually adequately fund a system before you assign risk, or there'll be it would be devastating to parts of our system. So I know we didn't talk about that. I'm sure I would have an opinion about it.
So the idea is that the regions would have a budget, but they wouldn't need to stick to them.
I think it was just vaguely that there'd be dollars, a portion, because I think the
Yeah.
discussion was more around that certain regions perhaps needed additional dollars to recruit and retain workforce, for instance, that there were different regional concerns that needed to be balanced. And that some regions and some areas might require additional resources or less resources. I think those were sort of the discussions, not about bearing risk.
That's what I recall too. It was more about different regions maybe having different needs for investments, or potentially different wages too, different wage scales. I remember that too.
Mary Lou?
I guess I'm going back to the slide that was before. on, when Mimi said the recommendations regarding regional entities. And from, I didn't track the task force entirely, but I listened in quite a bit and read the report, of course. But this is real, as I read it, it's more advisory to the state. And bringing those issues so that when, reimbursement things are decided statewide, that it gives reason why we're going to do something different a bit in this area or not, and responsible for convening and collaborating, ensuring the plan responsive to the unique needs, advising with relation to coordination, delivery of care, advising on budgets. So that's kind of the mentality that I took away and take away, that, and don't see really kind of reestablishing the CCO model.
Yeah.
Again,
Okay, I'm gonna let Amy talk, and then we gotta get back to
Yeah.
Mimi's gonna finish her presentation.
Yeah, I mean, and my comment was, if this is our focus in this direction, it feels like we're recreating the CCOs only like the original Cassandra dream of everyone on heaven OEB, and it's all through the CCOs, So I don't think that's why we're all here. So I just kind of wanted to.
Okay, go ahead, Handy, let's finish the discussion, then we'll get to more comments.
Okay, thanks everyone. This is a fascinating discussion. So what I'm talking about here, just these very, very basic, not comprehensive questions. I'm actually talking about the footprint of a regional entity and how you decide that footprint. So that's sort of like, how will the map be drawn? So some of the things that I put in there, well, what are the current administrative structures in existence? And I will give 3 examples of what we have in Oregon already. Of course, geographic boundaries in our state are very important. And as someone asked a question, well, what do you mean by that? And kind of my answer was, well, because I live in the Dalles and Gorge, sometimes I-84 is iced over and you can't get there from here. And that makes a big difference about the type of care that's needed where people live. Obviously, population size and the demographics, broadly the demographics, that includes all kinds of health issues. And then what's present already, the healthcare, resource availability. So if we have the next slide. All right, so this is something that is in existence, and folks who did a lot of work or any work during COVID-19 is probably very familiar with this picture. So this is the Oregon Healthcare Preparedness and Response Division. One thing that you will notice is that although it goes up to region number 9. In fact, there are only 7 regions. You will notice that number regions 4 and 8, still a mystery to me. I don't know how that is. But you will also notice that there are regional resource hospitals. There is one in every region with the exception of region 6, which utilize within the geographic boundaries, of that region. Region 6 does utilize the resources of region 1, which is OHSU being the regional resource hospital. If you want to go on to the next slide. All right, and so this is just a little bit different. So this is actually something, these are called hospital referral regions. This is actually set up on a national level. It's developed by the Dartmouth Atlas of Healthcare. And so the colors are the different regions, and is what you will notice is that they cross the state boundaries, because the regional referral hospital, the regional referral region, doesn't necessarily recognize state boundaries. And so as many people probably are familiar with, we'll give the example of that in Washington state, oftentimes the hospital of choice for very complex cases will be OHSU, which of course is in Oregon. So again, this is just another way to divide it up, but this is something to think about when we think about, I would say, especially this is very heavy on what are the medical resources, intensive medical resources that are available within a region. And then if we go on to the next slide, This, again, you don't need to look at the close type, but this is what our CCO regions look like here. And so there are 16 CCOs in Oregon. You will notice that there is some overlap of care in some of them. That's where the hash marks are, but certainly not in all of them. Obviously, physically, EOCCO, which is the Eastern Oregon Coordinated Care Organization, takes up the most space, but is not actually the largest in terms of population. So again, these are kind of existing regions that are already defined. All right. Thank you. That makes it a little bit bigger. And so these are the questions that we're asked to consider. And actually, Helen, how about I let you take it over from here? Because I think that this is how what the questions that you wanted to bring up.
Yeah, so I guess, the first question is there a value to creating regional entities? I mean, I guess we should start there and say, is that, if we're gonna operate a plan on a statewide level, is there a value of having some sort of regional entities? And if so, what should they look like? How big should they be? Should they overlap? Should they be profit or nonprofit? What is their role, just administrative, or how do they work? So is there agreement from the board members that there should be regional entities to have some sort of function in a universal health plan? We can do a fist of 5 on that.
I'm again feeling like we're having a backwards conversation. I don't know if I'm the only one in terms of digging into this portion before we've talked about the umbrella part.
What do you mean by the umbrella part? What should we talk about
The
first?
plan that is managed,
The single payer.
single
State.
state plan that is managed. And then this seems, it feels like we haven't really dug into that conversation enough as a board yet, it feels like, before we're having this conversation, but
So what would you propose that we talk about first?
how that operates before we dig into kind of the regional.
Yeah.
piece. I don't know if I'm the only one that's feeling like we flipped it backwards somehow.
I'm not sure.
I can understand, I think, what you're saying, Amy, and I too. But like I said, I kind of came into all of this in the middle of the movie. And so I'm trying to figure out what was done before and what.
Conversation.
Okay,
So we have a state level trust fund. We have a board that governs it. We are working on defining eligibility and the benefits package. And so the money lives at the state.
yes.
How does it go out? Is it just, everybody just kind of bills the state, or is there some sort of regional coordination? A regional budget, a regional way for people to express capital needs and community health needs, to report data and quality is in our overall umbrella structure. Is it just the state and then everybody, or is it the state and then some regional entities that have some at least administrative function, some reporting structure?
Yeah, I understand. It
Yeah.
just feels like there's conversations maybe that some people have had that not all of us have had. So even though I've been on the board the whole time, I still feel like I'm going in the middle because the framing around this conversation, I guess.
The question is just, should regional entities exist first? And then if so, should they be part of the structure of the universal health plan? And then we can sort through what their actual role is. With that, we are trying to have a high level discussion about sort of the nature of the universal health plan, like what it looks like and how it operates. And so that's just, should regional entities be part of our overall structure or not, is the question. Cheryl, go ahead.
I think from the health plan payer perspective, regional entities make sense. I think where I get stuck is regionalizing the service delivery system. I think that is difficult. It might be that certain aspects of the service delivery system can be regionalized, but I'll just give one example, like the crisis system. It's not realistic to cover all of that land when you're responding to crises within, I don't know, 30 minutes, an hour. It's just not possible. And so if you see that big swath of land in Eastern Oregon, that is not going to happen. So that's just, that's where I want to make sure I'm crystal clear on what we're talking about when we say regional entities. Are we just talking about the health plan function, the administrative services function, the payment function? Yes, that does make sense to me. It does not make sense to me to have overlapping regions. I don't think that makes sense at all.
Bruce, go ahead.
Oh, I'm a proponent of regional entities, but I just think we have to be careful about what we're talking about. I think that if I'm hearing you right, the discussion is about what should the regional entities do?
Yeah.
I think that's an important question. I think where the discussion, to me, has gotten muddy is we've been talking about bearing risk as part of a regional entity.
Yeah.
The discussion is first should be what should be the function, then we can talk about how many, should there be overlapping regions, but the first question is what should be the function and how should they be governed?
Yes.
Who should they be? But those are big questions that I think would be great to have some background information on. And so, to me, sort of to me, a briefing paper that sort of said, here's regional entities, here's what they can and couldn't do. That would then be a great discussion for us to have as a board.
Okay, so I posed the question, should regional entities exist? And that's how we got into this. So I'm gonna even take it a step back before we talk about what the role is. I'll go back to the question of, should regional entities exist? Should there be some sort of administrative structure on a regional level? And, Cheryl, to answer your question, just to simplify things, if we're just talking about administering services, it's just an administrative function. It is not about service delivery. Certainly specialist trauma centers, crisis response, all would cross regions. It's not about delivery of services. It's just about administering the health care in that region.
But I don't know what that means, administering healthcare.
Administrative functions.
Like what?
Paying the bills?
Because
I think
we're
that's-
trying to simplify that part.
Yeah.
Michelle, go ahead.
Thanks, Chair. The one thing that I'm also struggling in this conversation, but as I think about our overarching principles, I do think that regional entities closely align with at least 3 of them. And those are a community sense of ownership and governance. I think regional entities are really critical for that function. Also health equity. Thank you, Judy, for the shout out to rural Oregon. I do think that regional entities are a really important part of ensuring health equity and fair distribution of medical resources. Also, I think is supported by a regional entities model. And I agree with all of my colleagues that the specifics matter a lot, but kind of in abstract, and regional entities are not regional entities. I do think that the overarching principles support the direction of regional entities.
Thanks, Michelle. Go ahead, Randy.
I think I support regional entities for those reasons. But I'm thinking way back in my career to state health planning SHPTAs or I don't know, something, but they were advisory in nature. And that's what I've been thinking more, and maybe the some of the administrative stuff, but I think, and I know that the problems of, if a group is just advisory, well, fine, we don't listen to them, we just go forward and do what we want to do. So it isn't, a simple kind of thing, but I am thinking more of them as knowing their region, knowing the needs, having people have the ability to come and talk to somebody at a regional level and them giving that input. And I'm kind of going back to this, that everybody's going to be of good heart and wanting to make the right things happen and that, you know, we've seen sometimes recently in our government that that isn't always the case, but I want to believe Oregon still does operate that way. And so, but I really do see them more in an advisory capacity to the state entity, telling them about, let me tell you about the region over here, and what goes on out in Lakeview and Christmas Valley and other kind of places. And so anyway, I don't know if that's helpful or not, but I definitely had not been thinking of them as, kind of CCO 5.0.
Of course, yeah.
Okay.
So does anybody on the board disagree with the idea that regional entities should exist? Does anybody want to make an argument that we should not have regional entities? Okay. So given that we'll have some sort of regional entities, I would say we can come back and, you know, present a paper or presentation about pros and cons. But I would guess I would open it up for board members to say, Mary Lou brought up a great one about what the role of regional entities would be. And then, you know, should they have a role, you know, what is their role in the universal health plan? They're going to advise on community needs. What would be their role otherwise? We're open to suggestions, and then we can put together some sort of information packet, either a presentation or a handout about sort of things to consider for next time. But I wonder what your questions are, and then if any of the maps that Miriam showed made sense in terms of how many regions and how they would work.
I mean, I think the community governance that Michelle brought up is part of it, but I think there also would need to be representation from each of the regions, you know, within the state level.
Right, so community governance meeting within the region, that community decides what
The community has input.
on what.
Well, I think, I don't know what the what is until we figure out exactly what they're doing and what the umbrella is doing, but into, the needs of the community is able to,
So like how money is spent, or,
I don't know yet, we haven't had that conversation if that's what's happening at that level.
yeah,
So I don't want to say that until I understand the distinction between the statewide plan
yeah,
and.
it's up to us to decide that, so. I mean, or to make a recommendation about that, so like, I guess that's. I'm
Yeah,
just
I would not,
looking for
I would not
suggestions.
recommend that we recreate the CCOs.
Yeah, of course, yeah, so do you have a different recommendation, like, something that you would think would work better than the CCO model?
I was not prepared to have that conversation today.
Okay. Mary Lou,
I guess the one word that I wanted to ask Amy a little more, and I'm not putting you on the spot, but is when we talk about regional governance.
Mhm.
Governance to me takes on more than advisory
right,
capacity, and I'm not so sure. I'm torn.
I think in our values, we
yeah.
have community governance is one of the values about the entire
Okay.
planning model.
And I guess I'm not real sure what that really means.
And we haven't.
In terms of being, you know, when you're in governing, you're kind of in charge of,
exactly.
and
They
so,
charge of what?
yeah, and so,
Do they have a
because
budget?
that, yeah. I don't
Can they
know.
decide on capital purchases?
Yeah.
Do they contract with local providers? You know, these are the kind of, so when we're the board that's kind of coming up with this design, so we could come up with a couple of models to put in front of you, but I just wanted to get a feel from the board of like, what should those models look like? Like, what are the options? Or what kind of role these regional entities would take?
When I say community governance, what I mean is people with lived experience at every level, whatever the regional entities are doing, and the larger statewide plan that there is input.
I wish Dr. Chi was here,
I do too.
because I don't understand enough about, you know, the Taiwanese model, but, you know, they've got 23 million people and all that kind of stuff. I'm sure they have different regions, et cetera. So I would love to hear and know a little bit more about maybe how the Taiwanese and other ones that are like us, and how do they get that balance of making sure that in a very diverse state or country or whatever, that people are represented that are in remote places versus urban places in a state kind of model. And I guess that's what we're gonna have to grapple with. But I don't feel really prepared at this moment. I'd like to know more, and I guess maybe that's the briefing thing you were talking about, Bruce, that would kind of help us see what are some of those options rather than just starting with a blank piece.
Yeah, Judy?
Thank you, Chair. So my perspective takes it a little bit differently. And about Taiwan, Dr. Chi is well published. So if you used a database search, you could read a lot of his papers about Taiwan. I'll forgive Mimi for showing us the emergency map and the flashbacks of COVID, because it makes me remember the utility of that map was in resource allocation. And so there were times, if it's designed where there are non-duplicative regional entities that can coordinate around resource allocation. So there were certain regions who were at capacity or didn't have vaccine or whatnot, and they were able to level set and share across other regions or steer patient discharges or admissions so it was appropriate for the region. I think that's a real potential for this kind of regional entities that is not duplicative, that is intentionally designed as much as possible to limit geographic spread and to as much as you can look at demographic and risk adjustment of the pools if you go towards risk-bearing entities. But even if not, even if it is the role to be a convener for the community so that the community needs are spoken of, that ERCCO, they need coverage for like helicopter, right? Life flight, big ambulances. Not necessarily the case in Multnomah County, perhaps. So you have representation, you have a regional group that can align providers and ensure equity, but then also can coordinate up with other regions to level set when there are fractures in the risk pool such that there's variability that happens unforeseen to certain budgets. I think that is has huge potential.
Can we show that map again, please?
I think
No,
it's
the first one.
Yeah, that one.
This one.
That one. So obviously there would be like, the tension is between being small enough to be responsive to community needs, but sort of large enough to have the resources to, you know, be a meaningful aspect of the state. The CCO map, where there's 16 and overlapping, seems complicated. This map, you know, based on resources, seems a little bit simpler and a smaller number, having 7 regions instead of 16. If we have regional entities, does it seem like it should look like this?
I actually think this is, you know, pretty clean, but there is no region 4 and there's no region 8. But anyway, it's like, okay, but the clumps. But I do know that, you know, what's labeled here as 7 and 9, they are big geographic areas. And I bet you if I lived in Lake, I might not think that I'm, you know, getting the same whatever with Jefferson or, you know, I mean, it's or Deschutes has Bend, you know, kind of a bigger area. So the only thing that kind of, but I don't know how I would necessarily divide it, like region 7, maybe being 2 regions. I don't know if that's the case. The others actually look pretty good to me.
Bruce and Judy?
I would consider that we should actually expand the conversation to think about this as being governance of the entire plan. I think regional entities and regional input is critical, that healthcare is local. And I think having a regional voice to assure equity and fairness and quality and all those things across the state, and to understand every area is really different. I think it's absolutely critical, but I think it also has to be considered not how many regions you have, but then how does that interact with the governing?
Yeah.
is the governing board have one person from each of those on it?
Yeah.
Does it not? I mean, I just think this is about a larger structure. It's about how the whole plan is governed. And who should the governing board be?
Mhm.
And how this relates to that, but I think it's a great discussion because I think assuring that we put together a plan that actually gives voice to local communities is really critical. I don't know that I'm prepared to today, it won't be for quite a
Yeah.
while to determine whether
Where the
that's
regions-
7,
yeah.
9, 11, or
Yeah.
14. But I think this is what we as a board need to really grapple with.
Right.
And I think it's gonna take us a while to work through a lot of the issues that we've talked about today.
Right. Yeah, I just think it, like the more we can align our work with work that's already been done in terms of healthcare regions and stuff like that, it will just simplify things. Instead of creating brand new regions, if we can align with regions that already exist, that makes sense. Go ahead, Cheryl.
I agree that it will help us get to clarity and in connecting these regions to the governance function. That makes sense to me. And I would say, although this map of regional entities is closer in my view, I don't think it reflects what's going on now in terms of the CHIP and the CHA, the local planning efforts with the public health divisions and the CCOs and many other partners. So I would want to take a look at that too. Like, for example, I imagine the central Oregon, those 3 counties are a planning region. And I do think we should look to the local planning that we do, the assessments and the planning that we already do, and see if we can build on that work as regions too, or at least look at that and see if that might inform our decision. And then one other thing, I have to go join my national meeting. So I'll have to drop off for the rest of the board meeting, but I know you're going to take a break. So nice to see you. This was a great discussion. Thank you.
Just a reminder that Jenny and we brought to the board before the work of doing an environmental scan of the chips and shells that we could find current planning. So we can pull that back out. Our committee started that work.
Yeah, do you have a consolidated document about the chips and
Yeah,
shells?
yeah, we shared it with, or we asked to have it shared, and I don't know. Mimi, where did that end up? Remember, we were talking about that recently.
Yeah, yes, Isabel created a document kind of with all of the chips and chaws and a summary document that I think that we shared with you and Michelle, and if we haven't, I apologize. And so maybe at our next meeting, we can talk about that and how you would like that to be shared.
So there is work started on that.
Yeah.
Can somebody tell me what a CHA is?
Community health assessment.
It's, I think that, is it the hospitals that do the CHAs and the public health? I always get confused.
So, yeah, CCOs have CHAs too, and thing.
Yeah, I think they got brought in, but traditional is hospital.
Yeah. Community health assessment. And community
Okay,
plan.
thank you.
Yeah.
So it's the Willamette.
Yeah,
Right, so-
now that you say that, I know.
So, does anyone have any requests in terms of what you would like to hear more about in terms of things that are, things we would like some more information on, or things that we should bring to you? What kind of information do you need to help decide what the role of regional entities are and how large they are, what their function is? We can, gather some information so that we can decide what their role is, and just what kind of questions do you have? Good.
I guess I would be interested in, since we're developing a plan and a system that many other countries and other places have, I'd like to know if we could look at, some of those and see whether they have, how they do get input from, their other places than a centralized governing whatever. I don't know.
I think,
You know,
we can point you, I mean, I think Jenny did some of that in some of our earlier meetings.
So The Commonwealth Fund has an amazing website about this, where you
Okay.
can go country by country
Oh,
and get
good.
incredible detail about how they
Okay.
do it. That's not something we'll have time to present at a board meeting, but I can send that link around, so
That would be
you can
great.
read up on it on your own.
Thank you.
Yeah,
Yeah.
You send it to everybody.
yeah, of course, yeah, I'll send it around to the whole board, yeah. Isabel, if you help me remember the Commonwealth Fund site.
Okay. Thank you.
Yeah, and so you can sort of explore, but you know, I would point out, as we do that, that they're looking at whole countries that have universal health plan. We don't have any examples of states, with the
Yeah.
universal health plan, and so, it's different because they have, federal buy-in, of course, right? So,
But I just want to see if any of them have, referenced that they, even in a country like Great Britain or something.
yeah.
they-
So Canada's
you know.
with the provinces,
Yeah.
so the role of the Canadian federal government and then how the provinces work is a
Yeah.
similar type model, right?
Anyway,
So,
Thank you.
yeah, so we'll send that around.
Okay.
And Jenny also did an early analysis of, like, no states have yet been successful, but like what thinking behind the different states have been that have attempted, like, all together. So,
I mean, to your question, what information, I think it would be great to have a list of potential, and I would stress potential functions of a regional entity with some description about what that is and what could be the benefits or the problems in having that. And, with some specificity, because I think when we talk about administrative function, you need to dig down about what that sort of means.
Is that arranging transportation or is that managing all?
Michelle?
I also, I'm thinking a lot about infrastructure. If we're like, if we are, there's this tension that I'm feeling between tending to the context in which we are doing this work. If one of our goals is efficiency, reducing costs, increasing the efficiency of the healthcare system, which I believe that it is, then I think we have a responsibility to leverage the work that has been done in Oregon that can be a springboard without getting stuck and limited by what exists now. And so I'm thinking about the CCO 3.0 process, like what are the key lessons learned that are being reviewed right now? I think there have been some changes made as Oregon went from theoretical implementation to actual implementation of the CCO model of that iteration of regional entities around risk bearing, who bears risk and how that relates to quality and efficiency and what the some of the downsides of that are and then so I think some lessons learned from CCO 1.0, 2.0 would be helpful. And then where does infrastructure exist? Where do partnerships exist? There's a lot of trust building that's happened over the last few decades. Regional partnerships are an incredible part of our statewide infrastructure. And I think us at the state level saying, well, this region makes sense in a vacuum. If that's not where the partnerships are, and if that's not where the infrastructure exists, I think we're really doing ourselves a disservice, and that will cost us more time and money in implementation and probably undermine public trust in what we're doing. So those would be some of my requests for some of the information that could come back to us.
Well, have some of that. Some of it.
Yeah, I mean, obviously that would be something we definitely want to honor and consider and, but I'm not sure how we would learn of all of those as they're incredibly regional by definition, right? And so, what we can glean from the chips and chaws, certainly, but I'm not sure, I guess, that would be maybe part of this CCEC work to, when we're starting to shop around the plan to get feedback from different regions about if the way we've divvied things up makes sense.
Just an interesting point of information to Michelle's point about lessons learned. When we began to think about CCOs and regions, we actually thought that the Dartmouth Atlas Hospital Referral Districts was the appropriate thing to do. But we ended up with something very different because of exactly what Michelle was talking about, which was local community partnerships and regional partnerships and collaborations. And so the 7 hospital referral districts sounded great to, policy walks, but to the reality on the ground, it wasn't so great.
Wait,
And I just think that's a really interesting way to think about
so this one or
The Dart-
it. No, the Dartmouth,
The Dartmouth has 7 too?
yeah, I think so.
Is it this one? Oh, yeah. this
Yeah.
one.
So, but I've heard from other folks pretty clearly that we don't want to replicate the CCO model. So there's a tension there about like what they did well and what they
Yeah,
didn't.
I'm
well, right? Right.
making the point, and to what Michelle says, that, sometimes what's happening on the ground
Is different than paper.
is different than other things, and that we have to be sensitive to that and learn from those lessons, which I think is really important.
And I'm sitting here thinking about, as we say, we want all of this, and I'm kind of looking at Helen and thinking, who, do we have staff now that can do this? I mean, I just feel like we're putting a lot of weight on you.
Not me.
You're
I'm just your spokesperson here. No, it's us, all of us as a board.
Right,
It's
but
all of us
it's just kind of like, who's gonna do, and I was thinking, should we have a subcommittee on that, or a little task group, or should we do, I'm just kind of thinking this is a, rather big thing that we've opened up here and a lot of work, and so
Welcome aboard,
we have
Lee.
our new. And whatever, I understand it, feeling for the staff a little, and for you as the chair, so.
Yeah.
That's all.
We'll,
We say
The-
the royal we.
the staff and the leadership here will convene with our consultants and we'll see what we
Okay.
can come up with on our own. And what we might need and
Okay.
maybe bring back. Go ahead, Cheryl.
One other thing that I was thinking about that could inform our recommendations in this area is a bill that passed this past session, House Bill 2208, which clarifies this local planning process with CCOs and other system partners. We might want to take a look at that.
Did you say 2208?
Yeah, House Bill 2208, yes. And with that, I'm gonna have to leave. So good to see all of you. See you next month.
Thank you.
Might also look at public health modernization,
Mhm,
which talked about
mhm.
a more regional approach to public health in the state, moving from 36 different county public health departments to some way of thinking about public health regionally.
And then remembering there's some areas that don't have public health departments anymore.
I just have to give a shout out to public health modernization. Thank you, Bruce. You just made my heart beat faster. I can definitely do a little information on that. So it's a great call out.
We will kind of do our best to come up with a list of possible functions, a list of options about how to organize this, and then we'll kind of keep working through this discussion. Appreciate everyone's feedback. Okay, it's almost 10:30. Let's take a break until 10:40, and then we'll come back.
Okay. As I say,
Okay, welcome back, everyone. We are reconvening. And we're gonna get started with our committee updates. So first up for
sorry.
committee updates will be the community engagement and communications. Michelle and Amy, hand it over to you.
Teacher. Good afternoon, everyone. Michelle Glass, co-chair of Community Engagement and Communications. Our updates are one of which Mimi shared, which we're very excited about. We finally got through what we thought would be a much easier, much quicker contracting process because of the dollar amount. But we do have Patty Wentz on board. We're very grateful for her expertise, and she jumped in with both feet and has been, she already has multiple drafts that we are reviewing and that are going to the ECC committee. So we're excited that the work that this ECC outlined starting last fall is finally moving forward. So that includes a finalized communications plan, and as well as drafts of materials, as well as the overarching communications messaging guide for our work. And I'm looking forward to bringing that to you all as a resource for the committee work that you all are doing, so that when we take these draft plans, when we know that we'll have less of a timeline runway than we would all wish, that work will be already framed in a way that we can go out and do really effective engagement and get actionable feedback and buy-in. So excited to see all of that moving forward. The committee has also really been digging into and taking ownership of the style guide development work. And so thank you, Judy, for including one of the style guide recommendations in the mission statement drafts, which was people who live in Oregon. So this style guide is really doing some heavy lifting around. There are many ways that we could say the same thing, and there are some best practices. And so we're excited to also be finalizing the style guide at our July meeting and bringing that to you all in August as another resource. So our communications work plan is in full swing, and we are excited to be having some drafts that'll be ready for the board in the coming month or two. And let's see what else. Style guide. And then, as Amy mentioned, one of Patty's deliverables is also to write that RFP for the longer term, bigger dollar amount communications consultancy. Patty came in under that $25,000 one to get that backlog of communications work done, get us some basic materials to start with. But we are hoping to have that out as soon as possible, knowing how long this timeline has taken, even for the small, easier contracts. We definitely want to get that larger contract process started as soon as possible, so we can have that person in place when we are writing the final report and doing the incorporating the feedback from the community engagement next year. So our other consultant, Diana Bianco from Artemis Consulting, is still on hold based on the updated timeline for when draft plans will be ready. And so she is, she's going to come back. Our hope is to know enough in advance to bring her back about a month or two ahead of the draft plans being finalized, so she can look at where things stand and look at the straw proposals and things like that and start crafting those questions. So again, I will look forward to hearing in the other committee report outs if there are any updates to the timeline, but as of now, we are still planning for targeting around fall-ish. So maybe October for some draft plans. So bringing Artemis back sometime around September is the current plan for community engagement. Those are our updates, unless I missed anything, Amy.
No, I think you covered it all.
My quick question is there a way that we can increase the volume just a bit, or is it, am I just straining here?
That's all, it's maxed out.
It's maxed out, okay, I can hear, but I just kind of like, if the people who are speaking would try to speak up a little bit more, I think it would help. Thank you.
Okay, great. So next we have finance and revenue, and as mentioned, Cheryl had to step away. She's at a national meeting. So I think Mimi, you're doing the finance and revenue report, is that right? Oh, she's on mute.
She looks frozen to me.
She's frozen.
Mimi, can you hear us? Maybe go off video and
Should we skip maybe to another?
She's frozen.
Okay.
Frozen.
okay, we'll come back to you, Mimi, and move on to Plan Design and Expenditure Committee. That's me. I'm still serving as interim chair of that committee. At our July meeting, we spent a great deal of time talking about how providers are paid under the Universal Health Plan system. We reviewed both the statute and the task force recommendations about provider payments. And we decided, because it is such a complicated area of work, to really focus on primary care and how primary care might be paid in a new system. We are going to be taking up other aspects of payment in later conversations, but this one just focused on primary care. We had a subgroup of our committee that did some research for us and reviewed options for provider payments, including fee-for-service, capitation, salary, global budgets, pay for performance, bundled payments. And then we looked at the incentives and considerations for each of those payment strategies. We did look at payment strategies for other countries, and that's the resource that I'll be sending out to the whole board to look at. It's really informative about how other countries organize their payment systems. And then we discussed the role of ASOs, so administrative service organizations. These are third-party administrators whose role it is to process claims, but they don't bear risk at all in a system. They're just sort of have an administrative function of processing claims and making sure that organizations and providers get paid. The subgroup introduced us to a model from Connecticut that uses ASOs in their Medicaid population and the savings that they've achieved through that. We also spent a fair bit of time talking about Oregon's Primary Care Payment Reform Collaborative. This is another effort that was initiated by legislation to rethink how we pay primary care in this state. It's been going on for, I believe, 10 years now. They are nearing the end of their work to rethink how primary care is paid for. They have developed a model for paying primary care that has pretty broad buy-in conceptually, although not much uptake because of the competitive forces in the market. So a given primary care clinic, wants to come into an arrangement with a certain payer X to build this model, but that's only a very small fraction of the patients who are seen at that clinic. So it's hard for the clinics to sign on board because they're dealing with so many payers and only some of them are willing to do the model. Likewise, it's hard for some payers to buy into the model because their competitors are not. And so unless everybody's in, it's really difficult. But it could potentially, in a universal health plan system, it could potentially be a model for paying primary care that would have much broader support because of course it would eliminate that competing plans problem. So we spent a long time on that one. That model involves some prospective payments that are population-based, some fee for service, some support for infrastructure, and then a performance payment for quality. And those arrangements could be negotiated and depending on the provider group's willingness for risk. We don't have any straw proposals for this meeting. We're hoping to have a proposal for paying providers soon within the next couple of meetings, and no questions for the committees. Operations.
Michelle has her hand up.
Oh, sorry, Michelle. Sorry, I didn't see that.
No worries. I was just wondering if, I know we're all like just getting our consultants onboarded and that these are really heavy lifts for these, for your committee in particular. I was curious if you felt like the October timeline still makes sense for a draft plan to be available?
A draft plan for provider payments. So I think what we're doing, so I'm not sure that we're going to have a whole plan sketched out for how this is all going to work by September, but what we are sort of collecting is questions that we have for various groups of interest. So what questions we have for the business community, the questions or proposals or ideas that we have for the healthcare community, that kind of thing. So we're starting to collect those kind of questions. There's this idea that we'll have like a plan fully worked out that we can just put in front of people. I think that's still quite a ways off, partly because of our discussion today. Like, I'm not sure what to take away from our, we still have big questions that haven't been solved. I'm not sure what we would put in front of the public or our interest groups And I don't think we will have something really worked out by September, but we will have a number of questions that we could pitch to various groups. Yeah, so that's kind of, I think, where things stand.
So for our planning purposes at CECC with our community engagement consultant, we only have 10, her contract covers the 10 engagements. So are you suggesting that we would utilize, that your request would be that we take some of these questions out before there's a draft plan? And then we would, by the time there's a draft plan, we might not have the time or the slots left to get feedback on the plan as a whole? I'm trying to think how we would adjust, since our work really is supportive of the work of the other committees. We're trying to figure out what this iterative process looks like. So I'm really curious to dig into that updated concept that you just presented.
I think that we should sit down and work out a plan for Diana's work with Mimi and Lee and some of our consultants to think through what might be reasonable. I'm not sure I can speak to that exactly, but I think bringing Mimi and Lee into the conversation and thinking through how to lay that out and what we might have in place for those meetings would be a good idea. So maybe one of our follow-ups from this meeting will be just having Judy and I and Mimi and Lee sit down with you, Michelle and Amy, and figure out a plan, because I think it's becoming very pressing for CCEC, and we should just start laying that out, but I'm not able to comment on that right now. I'm not sure.
That's
That
all.
work?
Thanks.
Yeah, okay. Yeah, let's put together a meeting sometime between now and August. Okay, operations.
Operations, we did not meet this past month, so we do not have a report. We're meeting next week. But one item to put on the record that I know went out in an email to board members, but wanted to be certain it goes out further was, one of the questions that had come up at our previous meetings has been the issue of the kicker, and could the trust fund be subject to the kicker. And we got an email, some DOJ attorneys looked at that. I wouldn't call it a formal opinion, but we certainly got an email back saying that, their view was that the trust fund would be shielded from the kicker, that the legislation by the legislature contemplated setting up a separate trust fund and not having dollars go to the general fund for exactly that reason.
Excellent. Any questions for operations? It doesn't look like we have Mimi back.
Oh, I'm here. I'm sorry. I'm just staying off video.
Oh, there you are.
Oh, you
Okay,
okay.
Yeah,
Okay.
my apologies.
that's okay. Go
So
ahead.
apologies. Thank you again. So I'm covering for Cheryl. And so actually what I would like to do is if you'll move forward to the next slide, I'm going to talk about the current work. Apologies for the eye chart. But I thought that it was very important to bring forward to the board. So the main task and the main piece of work in front of finance and revenue is evaluating the revenue options. Now listed above, the list above this is taken directly from our consultant, our amazing consultant group, Equa Northwest. And this is of course not for anyone to make a decision on at this moment by any stretch of the imagination, but it is a sort of menu of options. And also as you go along on the top, you can sort of see a different criteria by which those different methods are evaluated. In other words, is this particular revenue option, is it equitable? Will it be sufficient to make up enough of the budget shortfall that we anticipate? How easy might it be to apply, etc. So I would love board members to, when you have the opportunity, kind of going down through this and sort of, taking a brief look. Again, it's not exhaustive, what I think is exciting too is that, so Echo Northwest is creating a tool in which sort of these revenue percentages, they can be altered to create different models. So in other words, sort of mixing different elements of, say, the personal income tax versus a payroll tax. And to be able for people to come up with a different types of plans that would provide sufficient revenue to make up sort of the estimated $22 billion gap that we're using as a benchmark currently. Echo Northwest will be presenting at our next board meeting in August, and they will also have this. Then it will be available to the board members, of course, as well as the committee members too. The plan right now is for the this tool is going out to the committee members, and the committee members themselves are going to take a look, sort of do a little bit of mix and matching, I guess I would say. So they have some ideas in their head of what they would like. Echo Northwest will collate some of those things and then bring it back to the committee as a whole. And of course, what we really hope is then that there will be some straw proposals coming next month to the board regarding some revenue options. So that was a mouthful, but I'll pause for a moment there.
I had a question, Mimi. I want to really like this grid. My question was just about the premium
Yes.
piece. You know, there's a couple of ways to think about a premium, and I hope it's actually both ways. One, you know, in our current system, we have basically back premium for people other than in Medicare. In Medicare, however, it's an income guided premium. Those who are wealthier pay a higher premium. And I just want to make certain you've got thinking about both of those. One on one side,
So,
the other
oh,
really
yes.
is an income-based premium.
Yes. Thank you. Thank you, Bruce. I think that I would say that definitely the committee is thinking more in terms of a premium being a sort of in a progressive manner. In other words, definitely income-based, but I think that's also, there is also the potential, and people again can sort of dial it into their model of having, as you said, a one size fits all. All right, this is a baseline, whatever it might be, premium for, depending on, you know, how that it's set up. So thank you. I'll make sure that that's included.
And Mimi, I think it's true, I had the same question, but this equity column, the first one, that is a rough gauge of the effect of these revenue sources on different populations from the standpoint of, does it affect, you know, like, would it impact people with more money pay more, people with less money pay less? That's the equity column. So that's an assessment of each of those revenue sources on that aspect.
Right.
Okay, yes. That's what equity means in this.
Yeah, so the progressivity, whether yes, progressive versus regressive, I guess is kind of what they're using there.
Yeah, so we asked Echo Northwest to present to us, so we'll have the straw proposal hopefully from Finance and Revenue next month with their recommendation of how we, you know, what the revenue structure would look like. But then folks from Echo Northwest will kind of go through this with us and show us different models and use the tool to explain different. And so if the board has more questions or wants to see other options other than the straw proposal, we'll be more prepared to do that in August at our meeting. So stay tuned for that, and we'll try and send out some information in advance so you can review it.
Right, and then that's really it from Finance and Revenue, but really getting into the meat of the work. It's great work.
Great. Thank you, Mimi. Go ahead.
I have a question that I don't know if it's the appropriate place to ask it, but I'm on that Finance and Revenue Committee. And something that was brought up to me by another committee member is, in our contract with Echo Northwest, will we own the model?
Yeah.
Thank you.
Yep, that was the problem that we've had with previous consultants.
Yes.
So yeah, that was particularly stipulated with
Thank you.
Echo Northwest. Yeah. Anything else? Okay.
That's really it for me.
Sorry, go ahead. Mimi, did you have something?
No, thank you. All done.
Okay. So we've reserved time on our agenda each month to talk about the federal and state policy updates. And there are a lot. This one. I wonder, is Janine able to join us? She's not on? Okay, so we can walk through these. We have a few minutes. So our consultants at Health Management Associates have put together a presentation that reviews the recent legislation, HR 1, that was recently passed, and its impact on health and healthcare. And I think it's worth just reviewing this quickly as a board, because it certainly will impact our work and the revenue that's available to us. So go ahead and advance. I'm not going to go into detail on these slides, but there's a lot of information here about what's that?
Anya.
Oh, Anya's here. Oh, forgive me, Anya, I didn't even ask. Forgive me. I had Janina in my head and I didn't realize you were here. Anya, can I turn it over to you?
It's quite all right. Yeah, and my camera is weird today. Yeah, I'm here. And I would suggest you just walk through this, and then if you have questions, I will try to answer them. And if I can't answer them, I will take them back.
A little louder.
We can't hear you.
We can't, our volume is all the way up on our end.
All right, thanks.
I think she said we just walk through them and then she'll be available to answer questions.
Okay.
Yeah. So the House Reconciliation Bill HR 1 went to the Senate, was modified, and then was signed by the president just this past few weeks. And then the following slides are going to go over the major provisions of it. Go ahead to the next one. So there have been some pretty major changes to Medicaid and the ACA marketplaces. The big Medicaid changes involve a 6-month redetermination. Currently in Oregon, we have a 2-year redetermination. That means people need to reapply and demonstrate their eligibility for Medicaid every 6 months now, which is a very big paperwork problem. It tightens rules on provider taxes. I have another slide that goes into detail on that and how that affects Oregon. Provider taxes fund about a quarter of Oregon's Medicaid budget right now. And so the tightening rules on that is going to impact our Medicaid budget. And then it restricts payment levels for state-directed payment policies to 100% of Medicare, which previously wasn't there. And then it creates a $50 billion rural health transformation program. This was in response to hospitals who were concerned that they would not be able to stay in business given these levels of Medicaid changes. So that's an attempt to sort of rescue the hospitals by providing some additional payments. In terms of the ACA marketplace, the eligibility for ACA subsidies is going to be changing. It's going to be removed for lawfully present immigrants. And then the ACA subsidies that are supposed to be, I think they expire at the end of this year. Those are not going to be continued. And then eliminates the cap on ACA subsidy repayment in your taxes. I'm less familiar with the Medicare effects. I'm not sure what the Orphan Cures Act is. Perhaps Anya, you could jump in and talk about the Medicare changes.
Can you hear me?
Yes.
Okay. I am not terribly familiar with these. It mostly has to do with the rate of increase. So Medicare has some automatic price or payment reductions that kick in every year unless Congress takes action. So I assume that the second and the third have to do with that. And this is kind of a normal event in federal policy that if not for congressional action, there's a sort of clawback of money, and this prevents that. I'm not familiar with the Orphan Cures Act, but could find out more for you if you're interested.
Okay, thanks. Next slide. So the estimates are that these changes would result in about $1.15 trillion reduction in healthcare expenditures over the next 10 years. That's across the country. And then subsequently, increase the deficit. And then the estimates are that there's about 11.8 million people who, because of these changes, will lose coverage, partly from reduction in eligibility criteria, but also partly because of paperwork and work requirements. So the eligibility requirements and the work requirements are an administrative burden, not only for the state level, but also for folks who have to fill out that paperwork all the time, and folks will lose their coverage even when they're eligible because of inability to keep up with the paperwork. Go ahead, next slide. So key takeaways: new administrative requirements for eligibility, the federal work requirements and Medicaid, which are slated to start the end of the year 2026. There's some room for asking for extensions on that. And then delayed implementation of previously finalized regulations to improve eligibility processes, enrollment processes. Next slide. This just goes over, so Medicaid is going to be having, of course, a lot of financial pressures due to lower federal funding and reduction of the provider taxes. States will need to find efficiencies and savings, so it's going to impact our general budget quite a bit and reduce payments. And then there's going to be a lot more uncompensated care as people lose their insurance. Go ahead, next slide. So on this slide, the HMA recommends scenario planning that incorporates additional federal developments like PBM reform, state budget and policy decisions as the legislatures and the governors navigate the program changes. I think there's going to be a lot of effects in general in our budget, and that may spill over into healthcare. And then operational efficiencies and revenue maximization are going to be necessary.
And I'll just note, I think that's supposed to be Medicaid, not Medicare in that first bullet.
Medicaid financial pressures.
The additional federal developments.
Medicaid payment legislation in the first bullet. And
Oh,
it says
okay.
right here.
Just that there will be, states will have to take action to deal with the cutbacks.
Yeah.
In
Okay.
Medicaid, not Medicare. I'm not sure why it said Medicare.
This is a slide I put together. The Oregonian did a really good article about the effects of this legislation specifically in Oregon. So I took this information from there. The estimates are that in Oregon, about 230,000 people will lose healthcare coverage. That's about 3% of our population. So we currently are covering about 97% of the population, and there are about 200,000 uninsured currently. And so this will double that number of uninsured folks. Oregon currently has a 6% provider tax, which, as I mentioned, is responsible for about a quarter of the funding for the Oregon Health Plan. And then over the next 10 years, it'll gradually be reduced to 3.5%. This will have a pretty enormous impact. The estimates are that in the next biennium, we're going to lose $872 million. And then in the following biennium, it'll be almost $2 billion. And then a total revenue loss of about $11.5 billion over the next 10 years. So this is pretty serious impact in Oregon to our budget. Next slide. And so there's a new work requirement for able-bodied adults between 1964 who became eligible for OHP under the ACA expansion of Medicaid. They will be subject to a work requirement of 80 hours per month of work, volunteering, or school. As I mentioned, this is slated to take effect at the end of 2026, but states can apply for extensions or could start that earlier. We will be moving to eligibility confirmation every 6 months instead of every 2 years. There's no extension of federal subsidies for the marketplace plans, which are going to expire at the end of this year. And the estimates are that marketplace plans in Oregon will cost on average $960 more per year in premium payments. And that'll likely push some people off those plans. The healthier people will probably stop paying for that coverage. Most of those folks are, individuals seeking care on the marketplace, and they'll drop off those plans, which would prompt insurers to raise premiums on everyone else. So even if you're not in a marketplace plan, it likely will result in premium increases across the board. I put this in here, it's not directly health related, but SNAP, is, of course, is our, nutrition program, funding for a nutrition program. And under the current legislation, they are gonna continue fully federally funding SNAP payments, for states that have an error payment rate of below 6%. But if states have a high error rate in their payments, then states will be required to pick up 5 to 15% of the cost of the program. And Oregon has one of the highest error payment rates in the country at 14%. So we're gonna, as a state, have to start contributing to the SNAP budget as well, which will have further impacts on
So
the
there
budgets.
can be, get it snapped, people who don't.
I presume, yeah, payments made in errors, yeah. Okay. So that's gonna be another impact on our budget. The good news, though, is that there was a provision to ban gender affirming care in the original bill, and that was removed from the final version. There was also a proposal to penalize states like Oregon that offer state-funded health insurance to undocumented immigrants, and that also failed to be included in the final version, which is great. The child tax credit of $2,500 was extended to 2028. And then from Governor Kitzhaber's presentation, I pulled in this little factoid that in the biennium that was 2011, 2013, there was a $3.5 billion revenue shortfall. That's what prompted this creation of the CCO. So we have been here before. We have dealt with major shortfalls before. And that issue was addressed with the creation of the CCO. So we were able to navigate that budget shortfall pretty effectively by healthcare reform efforts. So it was brutal. Yeah. Having been here.
So,
Yes,
is it okay if I pipe in a little bit?
yes, please, Anya.
Yeah, so most of this is a direct hit to states like Oregon and most of the states I've worked in over my career. In the sense that it's an attempt to reel back expansions of coverage and the financing that underpins that. Both the redetermination requirements and the work requirements are essentially administrative barriers, which if you've ever been a Medicaid director or in a Medicaid program, you know, there's a bunch of ways you can reduce the cost of the program. And one of them is that you just make the process harder. And a lot of states use this in tough budgetary times to make it so that your eligible population shrinks, because a certain number of people, if required to present paperwork, even if they're eligible for the program, will fall off because they don't get the mail, they don't know how to deal with the paperwork, whatever. It's an administrative barrier that inevitably results in people falling off coverage, and then that has kind of a snowball effect over the years, so that more people fall off each year. The ACA subsidies were always at risk. I think a lot of us in the health policy field thought that was the big deal this year. Like, are they going to cut back? Are they going to reauthorize the enhanced subsidies through the exchange? And this goes so far beyond that, that no, they're not reauthorizing those, and there's going to be some new requirements around ACA, around subsidies or tax credits through the exchange that are going to result in more people losing coverage. The provider tax is a big deal for a lot of states that have been trying to finance the program at the state level to sort of maximize expansion. It's not a small deal that the provider tax is going to be reeled back. That's a lot of money for a lot of states. And then I'll end on one other positive note, which is there is a rural hospital transformation fund, which is something that apparently was included in the bill, but then got expanded because that was how they bought the vote of Senator Mikulski. And it's a lot of money real fast. And so Oregon will have to think about who's going to receive that money. What's the plan for distributing it? It requires federal guidance by the end of August, I believe, maybe the end of September. So really tight timeline for the feds saying, what do we expect you to do? But there's a minimum federal allotment to every state. And it is 500 million over 5 years. And so Oregon's going to have to come up with a plan for how that money gets spent, in an application by the end of this calendar year that has to get approved by CMS for a wide variety of things having to do with rural health, including kind of health planning, and who knows what else, but it's very vague. It's a lot of money and it has to be spent fast. And so just know that that's out there. HMA is working on kind of rapid response. How can we help states figure out what they're going to do with this, particularly because states are going to have to do all that planning as a front end thing. You know, they're going to have to invest the resources in figuring out what is our quick plan for how we spend this money without funds from the federal government to pay for consultants or staff or new staff. So that's a good thing, but it's also kind of a bit of pressure.
Thanks, Anya. Any questions for Anya? Go ahead.
Yeah, I don't know, Anya, if anyone else knows, but there was a bill that passed fairly early in the session that was, I think, proactively trying to do some damage control around Medicaid and this bill. And I think the provider tax was a portion of it, but do we know if basically that bill's moved, or if the other pieces, you guys know what I'm talking about? I'm looking at the bill number. I think that Lisa Representative Fragala from my area was the sponsor.
There was a bill.
Was it 1113?
There was a bill to renew and alter how the provider tax
Oh,
is accounted for.
okay. So this isn't.
One other thing I should mention, just because it's sort of hot on the federal landscape, is 340B, and I'm not terribly familiar with the extent to which Oregon has embedded 340B in their funding, their financing of their health system. But to the extent that you have, that's another serious looming risk out there.
340B being the way that some clinics and providers can access lower cost pharmaceuticals through a special arrangement with the federal government. So that's not going to be, is it going away, or is it just reducing? I don't know what happened to 340B? Are they eliminating it?
I think the main target of the administration at this point is hospitals that have been using 340B. But FQHCs are probably at risk as well. So hospitals over the last 10 years have figured out how to use the 340B mechanism to essentially fund their operations by getting discounts on drugs, but charging the normal rate, and they get a revenue stream from them. And so that's something that's been at risk for a long time, but I think now is like right in the sights of the federal administration and many members of Congress. And it's particularly rural hospitals have used this a lot. So If that thread was pulled or that rug was pulled out from under hospitals, it would have a big impact on some rural hospitals.
Might be made up by the billion. There's gonna be a lot of accounting things happening.
Yeah, in terms of the rural hospital fund, that 50 billion,
Mhm.
like what I've heard is that that's in no way adequate to compensate for these kind of cuts. It's just a little bit of it's a bit of a gesture, but not gonna cover it. Is that right, Anya?
I think it depends on your state, because the allocation of the funds is kind of weird. Like there's a minimum $100 million per year for 5 years allocation. So if you're a state like California, big deal. That's not going to make up for anything else that came in by way of cuts in this legislation. If you're a small state, that may be a really significant chunk of change. And they call it rural hospital, but it goes to all, the base payment goes to all states, notwithstanding whether you're a rural state or not. So there may be some states, I mean, like I'm talking with Vermont and Rhode Island about this, and it's a big deal for them to have that much money dropped in their lap. But they have to figure out really quickly, what do we do with that money? How do we make a difference? And it's not money that can go to like well, I shouldn't say this. I think there are some restrictions, but it's pretty vague. So I don't think it can go to the direct provision of care, which is often true with federal grants and state by state allotments. But for some states, it'll be a really significant chunk of change. There is the ability for the Secretary of HHS to say, notwithstanding the kind of legislative mandate that we provide 100 million a year to every state over 5 years, per year over 5 years, I can deny a state application. So it's possible that there will be some sorting of states in the approval process. But the way the legislation reads, you get the 100 million, very broad purposes to which it can be put. You have to coordinate with your hospitals and your FQHCs potentially. But yeah, it doesn't make up in most states for the cuts, but could be a good thing.
One of the things that I still am a little hazy on reading the Oregonian and other places, but are these implementation dates. That, you know, things are not gonna change immediately, but they're gonna kind of roll in, and so. The Finance and Revenue Committee, as we try to figure out, you know, because what we've been based on was trying, getting waivers that is X amount. When put Y and Z and Q, that we can come up with the billions that we need. And it's just a little, and so I know our consultants will be looking detail into that to be able to have us see how much more state revenue do we have to raise through taxes to compensate for the fact that it's not a steady state of either what we have now and or thinking about usually the inflationary increase that you get. So it just makes the figuring it out how much we need from various kinds of taxes that will be Oregonians paying versus the federal government.
It's gonna be hard to sort out because like the work requirement that kicks in at the end of next year is the only clear deadline. Everything else is pretty much immediate, but the effects are gonna be people falling off healthcare.
Yes.
And so that's gonna be kind of a slow, gradual over the next couple of years as
Right.
people.
And that's
do that
why we're trying to
calculation.
plan how to build in, you know,
Right.
how to move this towards implementation.
Right.
So it just makes our lives a little more complicated and frustrating.
I know Family Foundation had a pretty good table but
Yeah, I think two important things there to recognize. It's a really good point. There's in any negotiation of a waiver with the federal government, there's a base year and base expenditures. So if you're diminishing, if you're running downhill from current expenditures, that's not a good thing. You want to be in a base year that's at the highest point possible. And then you negotiate a trend rate. Bruce knows all this very well. And so, yeah, to the extent that these federal actions reduce those base expenditures, that is a detriment to your starting negotiating position for everything you're designing.
I thought for the Finance and Revenue Committee, the bigger issue, the biggest issue is gonna be the changes to the provider tax. Because my understanding is we're relying on what Medicaid dollars we currently get. And as that ratchets down, those won't be available. So that's going to be quite a bit of additional revenue that would have to be raised some of it.
But we have our consultants.
The bill did create baby bonds, which is good news for a lot of families in Oregon. That's been something that is been tossed around for years, but children born between 2025 and 2028 are eligible for a tax advantage fund seeded with $1,000 from the government just for being born, and that can be tax advantage. So that's another financial advantage for low income. Anybody can access that, but certainly it'll help some families with funds. So that's good. Any other thoughts, questions on the federal legislation? Michelle, go ahead.
This isn't part of this specific bill, but another federal action that Kaiser Family Foundation has been talking about specific to Oregon is the impact of tariffs driving up prescription drug costs and the impact that's having on premiums. So I don't know how much of this we can account for. I know there's a lot of instability in the tariff conversation, but just wanted to note that as another trend in the cost of healthcare that that Kaiser's been tracking, that I've been reading a lot about.
Okay, so we have already started a list for future meeting topics, things that you want us to look into. Does anyone have any other requests for information to be brought back in future agendas, other than those we've already discussed?
You want more?
Yeah. Okay,
twist, we want more.
any updates on board outreach, requests for outreach or presentations you've done?
Since the last meeting.
Quiet some, okay. Great, then I think that wraps up our meeting. We have a final reflection. Oh, sorry, I forgot about public comment. I'm sorry. Yes, I apologize. I'm not watching my notes. Okay, yes, let's move to public comment then.
We have 4 people signed up for public comment today. I will get the timer on the screen. And we have 2 people online and 2 people in person. Lou will be the first speaker. So Lou, whenever you're ready.
All right. Can you see me or hear me?
Can hear you.
Hello?
Yes.
Okay. Well, once again, here we are. The federal account is not good news, but you know, we have to go ahead one step at a time and try to get this. I was particularly interested in the regional conversation. I look at regional first of all, I think we have to keep it simple as possible. So if you set up regional areas with administrative, that's going to complicate things in my mind. I believe that that the regional thing is really great because it would give community and it would give people set up a system by which they can give feedback on how well or what they need in terms of their health care, right? You know, you're kind of stuck in trying to get oh, one thing I wanted to cover is as far as regional areas for public feedback, I think the congressional areas have already been mapped out for us and people identify with those areas. So please consider that. That'd be really good. As far as, you know, how methods of payment and all that, just go ahead, figure out the cost of the program and how it's paid for now and pay it that way. Because what you're trying to do is establish, you know, cost controls without really knowing the costs yet. Sometimes I consider that what you're trying to do is build the perfect car without ever having driven one, right? So my advice is let's try to keep it simple as possible. We all know that it'll change through time. Thank you.
Thanks, Lou.
Thank you. The other person who was online, Mike Hutchison, is no longer online. So I think we can go to the folks that are in person to give public comment. Tom, we're the first.
Okay, thank you very much, Tom Sensick again, family nurse practitioner with Nurses and Friends for Single Payer. Regarding the budget coming forward, it's a new fiscal cycle with a new budget allocation of about 1.8 million or so. It is up to this board to determine within the confines of the state rules how the money is spent. In other words, the board needs to approve a budget for the next 2 years and spend and adjust accordingly, while perhaps giving the ED some latitude on the expenditures. This needs to be at the top of the agenda. This issue is not addressed in the previous biennium. Now is the chance for a fresh start. I want to go back and reflect a couple of items on the regional entities. When it was written for the task force, those regional entities was meant to be not the board creating new entities, but to talk with the current existing regional things like county health departments, CLO, regional health equity, wherever tribal communities, you know, there's already a bunch of them. The board may later decide we need some different configuration of regions. But first of all, start by getting a list of what regional entities exist. Why was the word entities used? Because there was a hospital district as an entity. We didn't want to list out every possible one. We didn't maybe know what every one was. So think about that. Just get a list of current regional entities. And then as far as risk bearing, I'll go back to my initial comments. The state is the first group to bear the risk. There should be no further discussion on where the risk bearing is. It has to
That's
apply to the state. That's what is the directive. Thank you very much for your time and all your service. You've done great work.
Thanks, Tom. And finally, we have Colin.
Hi, hello, thanks. My name is Colin Stackhouse and I work with Healthcare for All Oregon, but I'm here speaking just as an individual and a patient advocate. I have 3 topics I'll try to squeeze in the next 2 minutes. The first is echoing Tom's sentiment about the risk bearing for the regional entities. When I spoke about the work with the board to a family member who is a small clinic, rural physician in Douglas County, and I mentioned that potentially expanding or extending the work of CCOs as the regional entities for this universal health plan, she immediately recoiled and talked about the reality that she perceives, which is that regional entities currently are incentivized to ration care, which is something that Judy mentioned as a potential problem that we don't want to continue. If regional entities that in this new universal health plan have that incentive, then the care will not improve as we all intend with this new universal health care plan. So that's one thing that I wanted to bring up, that a physician family member had a big reaction to that when I mentioned CCOs continuing in that format. The second thing I wanted to mention is sort of bemoaning also with an understanding of like this continued delay of a potential first draft of the plan. I remember hearing members of the board say very confidently, we have a first draft this summer, and then later on very confidently saying we'll have a first draft this fall, and now hearing that we don't have a timeline for a first draft of the plan. I do have some hope with the Finance and Revenue Committee's the recent slide that I want to dive into about premiums. One of the questions we get at HCAO is just about the cost, right? And so we don't have anything firm to tell people when they ask us questions about that. So a little bit of bemoaning, also mentioning there's a little bit of hope. The third thing is just encouraging the board to try to consider, if we can, contingency plans for if we continue to have a antagonistic federal government cutting our ability to use Medicaid funds in the final plan. Thanks.
Thank you.
Thanks, Colin.
Yes.
Mike didn't rejoin. Okay. Okay, yeah, great, all right. Watch my notes. Okay. So that wraps up this meeting, as a final reflection, do you have the last slide? I pulled in a couple of quotes from, Governor Kitzhaber's presentation that he gave at our strategic, board meeting. You go to the next slide. These are bullet points that he had in there, that healthcare is perhaps the only business that produces goods and services that almost none of its customers can afford. And that healthcare itself is not just another economic commodity. The delivery of healthcare involves an ethical contract, not only a contract between practitioners and those seeking care, but also a contract with society as a whole. And his charge in this talk was that the overarching priority is to address the total cost of care, that if we don't address the rising costs, that it will eventually sink the system. And so keeping a focus on how to manage the cost of care and not just assume that we can continue to increase our spending without reining that in is gonna doom the effort to failure. So keeping those things in mind. And we need a volunteer for next month's reflection, please.
I will, Chair.
Okay, Judy, thank you. Great. Any final thoughts for the good of the order? Oh, great. Thank you all for
Thank you.
attending. We're adjourned.
Thank you.
Thank you.
Thanks.
Hard work.